on to part 4, the final part of this lengthy, in-depth video. And it's called Emerging Treatment Strategies for Fatigue and PEM. So in this section, I'm going to talk about these strategies, whether these ever emerge into the mainstream or not, and I'm going to also share some of the unfortunate limitations of these strategies. It's worth studying them because every new treatment we study teaches us something about the biology of what we're studying, in this case, fatigue and post-exertional malaise. So I'm going to start with the most controversial management question, and I've already hinted at it in the previous section, and that is whether activity, movement, exercise can be therapeutic in people with PEM. One of the most common questions I have emailed to me is how to decrease fatigue and PEM so that people can get back to the life that they want to have, the activities they love. Most people with ME, CFS, FM, and long COVID have had repeated failures trying to increase their activity level. They try a program, they increase their activity, they push through, and then they crash. When this occurs repeatedly, we call it the push-crash cycle. So here's the dilemma. It is just a truth, unfortunately, that we only become stronger and more resilient if we challenge our bodies. So in healthy individuals, muscles and other body systems become stronger and more resilient in response to activity, to basically carefully executed and timed stressors. And we know through observations of the epidemic of chronic disease in our modern society that our inactive, stress-free, physical stress-free environment causes the body to lose capacity. But if you have PEM, how are you going to utilize this built-in capacity of our body? So the goal is to find ways of moving and challenging the body that will allow the benefits without causing a crash. Now, the response to activity is an area where managing fatigue in the absence of PEM and managing it in the presence of PEM is very, very different. We can use people with fibromyalgia as an example. Some people with fibromyalgia also have PEM, but many do not. They have fatigue and brain fog and unrefreshing sleep and sometimes mood problems, but they do not always have PEM. And interestingly, as a group, the research repeatedly shows that people with FM who do regular aerobic exercise show small improvements in quality of life, pain, stiffness, physical function, and fatigue. And this is based on, I'll say, dozens of studies. Now, for people with fibromyalgia who do not have PEM, aerobic activity is slightly better than strength training in terms of this benefit. So, for example, a lot of people find a regular walking schedule, if they watch their heart rate, don't overdo it, and take rest days, helps them feel better. There are some really important caveats, however, even for people with fibromyalgia. The improvement reported in the research studies is very modest. It's in the range of about 10%. This is pretty small. Additionally, people in research studies are coddled, right? Because the people doing the study want to have a positive finding so that they can publish it. So the people in research studies are given careful instruction, how to exercise safely, how to monitor themselves so they don't overdo it. They're often in live classes where they're with expert coaches or practitioners. Their progress is monitored at regular intervals. By contrast, the ordinary patient who's working with their family doctor or physiotherapist might be given the advice to exercise, and that's it, and they're not told how to do it. So people given vague instructions without expert guidance are probably less likely to improve than people who are in the research studies. Exercise prescriptions need to be tailored to individuals. We are all so different. There's no such thing as a uniform, successful recipe. So you want to take into account things like personal preference, like what type of activities do you enjoy? Are you the type of person who likes to exercise with others or by yourself? Do you prefer to go to a class outside your home or exercise in your home? Does it work better for you if you go walking with a friend or you're kind of in your zone with your with your earphones in? So the trick is to find out what works for you because as they say in the field, the best activity to do is the one that you're actually going to do on a regular basis over time. Now, post-exertional malaise is different than fatigue. So I've just explained that if you have fatigue without PEM, moderate aerobic or strength training exercise with expert guidance can be beneficial. If you experience post-exertional malaise, the goal is not to focus on activity level, but rather to avoid crashes. The consensus is growing, and I would say deafening, very strong, that to recover from a complex chronic disease that involves PEM, it is necessary to avoid crashing too hard and too often. So you might be thinking to yourself, how does one do that? The answer is pacing. So then you might ask, okay, what is pacing exactly? Like a lot of people throw around these terms without defining them. So pacing is accommodating your activity to the amount of energy you have. We often call that the energy envelope. So the goal of pacing is not to push through and do what you had planned in the day, but it's to accommodate or change your plans to stay within your energy envelope. What this means is that whatever you do today, you want to be fully recovered within 24 hours. For people who are severely ill, this is difficult to impossible. So it takes a lot of motivation and I'm going to say skill and learning about your own body. It's easier said than done. To help people with this goal, I've developed a strategy that I call deep pacing with a capital deep. The goal of deep pacing is to not only learn the strategies of pacing, but also to overcome what I call the attitudinal barriers. Many of us know how to pace, but we don't do it because we don't want to. It's not that fun. And because we may harbor pesky beliefs that we're lazy and we should just push through and everything would be okay. So if you want to learn more about deep pacing, you can find the webinar on my webinar sales page on my website. So to summarize the use of exercise in fatigue and PEM, if you have fatigue but no PEM, meaning you don't crash hard the next day, you may benefit from increasing your activity level. Find something you enjoy that is within your energy envelope and find the right dose and the right frequency and the right amount of rest that allows your body to capitalize and progress. If you have PEM, your overarching goal is not to get more fit, but it's to avoid crashes. Research, again, by Dr. Leonard Jason shows that crashes set you back, and the people who stay within their energy envelope and avoid crashes for 6 months end up at a higher level of energy than people who repeatedly crash. It's slow and it's not that fun, but it does work. So now I'm going to move on to some other emerging treatment strategies that I would call in the pilot phases of research. But the exciting part is at least they exist. At least they're being tried by different research teams. So the first of these is mitochondrial support. We know the mitochondria are not functioning optimally in people with PEM. And The thought has been by many that if we gave the mitochondria everything they need to function, they would do better. And this has led to many studies and recommendations of providing what's called mitochondrial cocktails or mitochondrial support. Now, in my experience, even though there is research out there showing it works, and even though many very credible, respected practitioners promote this approach, I have never found it in my practice or in my personal experience to be that helpful. So there are a few people that benefit from adding things like magnesium, B vitamins, CoQ10, D-ribose, NADH, things like that. But I've never found the results to be as significant as advertised. Now, my thought about why this could be the case is that many people whose mitochondria are underactive, they're shut down in something called the cell danger response, which I've talked about many times. And when the mitochondria are shut down, giving them the molecules they need to function isn't enough to shift them into oxidative phosphorylation. Probably what needs to happen there is an overall body-wide sense of safety and also trying to find and shift underlying causes. What caused the mitochondria to shut down in the first place? Even in people where so-called mitochondrial protocols are somewhat helpful, they're generally expensive and therefore hard to maintain over the long term. Now, some newer therapies being tried are therapies to balance the immune system. If PEM, post-exertional malaise, is related to inflammation, then it stands to reason that anti-inflammatory strategies may help. However, like everything else, the truth is more complicated. Many people have tried regular anti-inflammatories like COX-2 inhibitors in pilot studies, and they just haven't worked. So researchers are looking for other ways to calm and balance the immune system. Some of the strategies that are being looked at the moment, one is immunoabsorption. So this is a therapy where the blood is filtered and there's the ability to remove specific autoantibodies. This is probably the leading group in this is at the Charité Hospital in Berlin. And they are reporting some modestly positive findings, but I would say it's at the early stages. It's not a widely available treatment, and controlled research is necessary to figure out who may benefit, because at the moment, many people aren't benefiting, and to ensure that the treatment is safe. Another treatment that's kind of re-emerging onto the scene is intravenous immune globulin. Now, this was kind of popular 20, 30 years ago in the ME field, and it's experiencing a bit of a resurgence. A recent study of IVIG, intravenous immune globulin, in long COVID patients with neurological symptoms showed a positive response. And as a result of that, there's 2 large-scale studies currently underway, which I have talked about in a previous video tip. Now, a couple of cautionary notes. According to my reading, even when successful, the benefits of IVIG wear off within about 3 months of ending treatment. So what that implies is it's not a cure, but it's rather a palliative measure. It's very expensive and it's not widely available. So for example, in Canada, IVIG is not offered to people with ME. This means that even if the research currently underway shows benefits, the average patient is probably going to be unable to access it. The last category are treatments seeking to improve blood flow and oxygen absorption by tissues. So the first of these is Hyperbaric Oxygen Therapy, HBOT. This involves breathing 100% oxygen under increased pressure, usually around 2 atmospheres. This means the pressure in the chamber is about twice the pressure of our atmosphere. And this is used in many other conditions. For example, people that get the bends from scuba diving and people that have wounds that are not healing. So HBOT is reasonably available in most, we'll say, major hospitals. And the research shows that in general, HBOT improves the blood flow and oxygen availability. When there's more oxygen in the blood and the tissues, this improves mitochondrial function and energy production. And really exciting, it actually increases the release of stem cells and has anti-inflammatory effects. So this all sounds amazing. Now, they have been trialing HBOT in long COVID, and they have found some positive results, things like improved quality of life, improved sleep, decreased pain, and improved cognitive function, and more studies are underway. A caveat or a drawback is that, like the others, it's a very expensive treatment. Most people estimate that you need a minimum of 40 treatments to have a positive effect, and in most locales, treatments cost somewhere between $200 and $300 per treatment. So very, very expensive. Now, I tried HBOT many moons ago, probably about 20 years ago, and I did have a very positive effect after 40 treatments. But unfortunately, the effect wore off after 3 to 4 months. And apparently, this is quite typical. And I just felt like the expenditure of time and money wasn't justified by the amount of benefit that I had. So, again, although this may prove to be an effective treatment, it may not be available for the average person. Another line of treatment that's being tried is to address this apparent microclot formation. And there was a recent meta-analysis, meaning a study of studies, which showed that anticoagulant therapies, so basically therapies that thin the blood, reduce the risk of major blood clots and death in people with long COVID. Now, unfortunately, this paper wasn't really looking at quality of life and didn't report on PEM. So, although it may prevent people from dying, we don't know if it will help them feel better while they're alive. So, the good news is that research is advancing, and I think more people are stepping outside the box and are trying off label treatments. So, all the treatments I've just mentioned are off label for this use, meaning they're available, they're science-based, we know they're safe enough to be used in other disorders, and people are thinking, I wonder if these would work in people with post-exertional malaise. The research in the field is increasing exponentially, and I really think this is due to long COVID. We are getting many more skilled interdisciplinary research teams forming in several countries. Collaboration between groups is increasing, which is really exciting, instead of the siloed approach of the past. New researchers are joining the field, and they're bringing very exciting, diverse types of expertise with them. ME and long COVID, while not at the top of the totem pole in terms of respectability of an area of interest, are at least now considered legitimate areas of exploration rather than being labeled as career killers. Many of the new findings of what's going on, so there are many new findings about what's going on in PEM. And although they're not yet at the stage of being translated into treatments, while there's new information being discovered, hope continues to increase. The downside, so that's the good news. The bad news is that there's often a frustratingly long delay between the discovery of some abnormality and figuring out how to fix it. Often things sound really good in theory, but they fail to translate into gains for real patients, even in controlled research studies. With so many systems functioning abnormally, basically the whole body, the goal in PEM research is to find something that's way upstream, right? That if we can fix it, it's going to cause a whole bunch of dominoes to fall and have a positive effect on things that are downstream. I hope you've enjoyed this in-depth four-part series on fatigue and post-exertional malaise, what they are, what causes them, and maybe what can help us recover. Keeping one's finger on the pulse, I have to tell you, is hard work. I'm actually working just as hard as I was when I was in medical practice. And my goal is to save you time and energy by doing the research for you and in sharing important advances in concise, digestible bits across multiple formats tailored to your preferred learning style. I share what I'm learning in real time through video tips like this, my blog, my new podcast, the Dr. Eleanor Stein podcast, and in my subscription-based membership, Live with Dr. Stein. I welcome your feedback about all of this material. You keep me on my toes and you keep me learning more. So thank you very much, and I look forward to hearing from you.